Adenoid cystic has a very high association of perineural because of some nerve cell adhesion molecules, and about 60% of adenoid cystic have perineural spread. So the moment we get an adenoid cystic carcinomas as an histopathology, we are very, very particular to hunt for perineural spread in our scans. Mucoepidermoid melanoma and lymphomas also have perineural spread. Based upon the nerve involved, the maxillary nerve, that is the V2, is the most common nerve for the perineural spread. Though we also get in V2 and V3, both of them are commonly involved, basically the trigeminal nerve, followed by facial, the V1, hypoglossal, and the communication between 5th and 7th. These are the nerves which are commonly involved. So how do we image this? Obviously, if we are looking at nerves, the MR is definitely better than a CT with a sensitivity of about 93%. Because of the high resolution, the MR is better. So we are going to take a high resolution scan, small FOV, thin images without gap. That is the basis. Now, when we are looking for head and neck, we are seeing the nerves against the background of fat. So we want to see the nerves, we don't want a fat set images. So a thin T1 non-fat set and a thin T2 non-fat set are the best planes to see the small nerves. We want to pick up the pathology, so one stir we will need, or a fat set image. CIS is helpful only when we are looking at the intracranial segment when there is fluid around the nerve. So for intracranial segment, we need a CIS, and we need a 3D post-contrast T1 fat set, which should be thin and can be reconstructed in different planes. We do need a CT as a supplement, especially the bone algorithms. Now, what are the imaging features that you will look for? What happens in perineural? The blood-nerve barrier is disrupted. There is increased capillary permeability, so the nerve starts enhancing. Later on, the nerve enlarges, and as the nerve enlarges, it then erodes. It may enlarge a foramen or it causes destruction, which are the secondary signs. The asymmetric enhancement of the nerve is hence the first sign. We also get denervations, that is the secondary feature. Now, what happens in a denervation? How does the muscle look like? In an acute denervation, the muscle is bulky and edematous and shows post-contrast enhancement. Whereas in subacute and chronic phases, slowly the fatty replacement starts, the muscle starts losing its bulk and becomes atrophied. So now we will look at some of the cases and understand the nerves and the perineural spread. So we look at Buccal-CA, maxillary, hard and soft palate, parotids, and nasopharyngeal carcinomas mainly. How do you approach for the lesion? When we look at the primary, we look at the symptoms and bone involvement. Depending upon the primary, we will check all the possible nerves in the vicinity to see if any of the nerve has a perineural spread. To look for the nerves, we have definite site or the definite landmark where we would like to check these nerves. We would look at the nerves both as a retrograde manner and as an antegrade, any other nerves involved. This is the way we approach for a perineural. So before talking about the perineural, let's look at the normal anatomy of the trigeminal nerve, which is the most commonly involved nerves. So the trigeminal nerves, it's located, the root is present in the pons. It comes out through the mid pons. This is the cisternal segment. After the cisternal segment, it enters the Meckel's cave. This is the coronal of the Meckel's cave. What happens to this nerve in the Meckel's cave? It divides into 3 branches, we all know. The first division, that is the ophthalmic. It pierces the dura and enters the cavernous sinus. The second nerve, which is the maxillary, also enters the cavernous nerve, which is the mandibular. It never enters the cavernous sinus. So if you are tracing your mandibular nerve, it will not go to the cavernous sinus. It travels beneath the dura, comes out to the foramen ovale, and from there it comes out of the calvarium. So first we will look at this mandibular division because it is most commonly involved in buccal carcinomas. It is largest of all the 3 divisions, has both motor and sensory supply and supplies the muscles of mastication. After it comes out of the foramen ovale, it divides into small interior branches which supplies the buccal area, masseter, and the muscles. Whereas it has a larger posterior division which divides into 3 common nerves, that is the inferior alveolar, lingual, and the auriculotemporal. Let's look at the inferior alveolar nerve, which is most commonly involved nerve in buccal carcinoma. This inferior alveolar nerve travels out from the foramen ovale, comes out into the parapharyngeal space, enters the mandibular canal, travels into it, comes out through the mental foramen. This is its normal pathway. So this was a case of buccal carcinoma where the ramus was destroyed. Slide is not moving. Okay. Should I share again? Wait, let me see. Is it seen now? I have made it in PowerPoint mode.
We can see
Okay,
the case.
fine. So from where should I start? Can you write in the chat box? Mandibular nerve anatomy. Okay. So mandibular nerve. Okay. So the third nerve which comes out through the foramen ovale, and this is the mandibular nerve. So it's getting stuck.
So yeah, I can see it moving. Just do it again.
Is it okay now?
Yeah, we can see the slides. But this is the anatomical slide, right? With the illustration of the inferior alveolar nerve.
Let Is it seen now? Is it in?
Now we are seeing the mandibular division of trigeminal.
Akshay, your voice is not clear.
Right.
Maybe my net is.
Is it breaking? Hold on. So we can see the diagram of the inferior alveolar nerve. Or maybe this thing is slow. Let's rely on the chat.
Is it okay now?
Yeah, all
Okay.
the comments are saying it's okay.
So this mandibular nerve comes out through the foramen ovale, extends into the parapharyngeal space, enters into the mandibular canal. We will see it in detail. Now this was a case of buccal carcinoma where there was destruction of the ramus. As we look carefully, there was soft tissue in the mandibular foramen. There was this thickened nerve which is traveling medially, crosses the pterygoid and comes into the parapharyngeal space. This is the normal pathway of a mandibular nerve in the cases of perineural thickening. This was another case when the fat of the mandibular foramen is obliterated. So it is easy to check for any asymmetry or obliteration of the fat in the mandibular foramen, and then you can check the nerve obliquely in this direction from the mandibular canal to the foramen ovale. This was another case of an MR on a T2 weighted image when the soft tissue was present at the mandibular foramen. The nerve traveled medially. This is the pathway through which the nerve travels. It crosses the medial and the lateral pterygoid, comes into the parapharyngeal space, and then it travels superiorly straight. This is the pathway of the spread. The same thing in a post-contrast image. Once you know the pathway of these nerves, it is very easy to trace this nerve. So let's look at the normal anatomy. So this was the mandibular foramen. The nerve travels over here. There is always a vessel behind the nerve. So that is another way to identify it. It is going to cross this. When the muscles are cut like this, the pterygoid muscle, hunt for the nerve posterior to it, and you will see it as a dot. This is the nerve traveling. It will cross the pterygoid muscles and enter the parapharyngeal space. Till this, it is very easy to identify on the CT image. Now, what happens over here? Over here, you have started seeing lots of dots. The pterygoid plexus comes over here. If you feel you are not able to identify the nerves over here, it actually becomes difficult. You may ask for an MR at that level. Once it reaches the parapharyngeal space, it normally travels straight, and if you keep your pointer like this, you will enter the foramen ovale over here. You can try to trace the nerve on the coronal once you are confused with your plexus on an eggshell image. It will be seen coming out like this and then traveling superiorly. So many a times the plexus can be avoided, and if you will be able to see if your nerve is really thickened or not. If you are really unsure, ask for an MR, because rather than calling not being sure about the foramen ovale involvement, it's better to do an MR in these cases, and the nerves will be better seen. So another case of mandibular nerve involvement, nerve coming out of the foramen, traveling laterally, traveling behind the pterygoid muscles, coming up in the parapharyngeal space up to ovale. Associated CT findings in these cases may be the enlargement of the mandibular canal. And even if you find your buccal mucosa sitting at the mental foramen, check for a perineural in this direction. So this was a very interesting case. It was a case of left submandibular gland carcinomas. Now these submandibular duct carcinomas are especially very aggressive tumors. So what was seen in this case? It was destroying the mandible. And you have learned during your first year MBBS in the anatomy of the mandible that there is a lingual sulcus present through which the lingual nerve travels. So there was a thickened structure over here. What are we actually dealing with? What was this structure doing? This structure was traveling, crossing the pterygoid muscles over here and coming out in the parapharyngeal space. Is it an inferior alveolar? But this was little different from inferior alveolar. Let's trace back. We'll go back in this. So this thickened structure was there. This was your mandibular nerve. So this nerve, which travels like the mandibular nerve, anterior to it is actually a perineural along the lingual nerve, which was going up till this. Now let's see the opposite direction, just to understand the anatomy. I will again describe it while describing the auriculotemporal. So this is the nerve which travels anterior to this mandibular nerve over this. It goes into the lingual sulcus. I will describe it again in the next case. So this is the direction in which it travels, the lingual nerve, just anterior to the mandibular nerve, inferior alveolar nerve, sorry. This was a case of parotid carcinoma, and there was a perineural in the foramen ovale. So how does a parotid tumor spreads to the mandibular nerve? This spread is through this direction, and this is the auriculotemporal nerve. So if you find a perineural which is like partly encircling this condyle in this fashion, you are probably dealing with a perineural along the auriculotemporal nerve. So let's look at this case. Here there was a thickening of the mandibular nerve. This is a normal nerve on the left hand side. So this nerve is thickened. Here it has divided into three: lingual, inferior alveolar, and auriculotemporal. Here everything is thickened. This thickened structure, which is traveling to the parotid tumor, around this condyle is the auriculotemporal nerve, or the third division of the mandibular nerve. It had gone and caused perineural into the main mandibular nerve, and then there is an antegrade spread into the lingual and the inferior alveolar nerve. Okay. So this was another case of a parotid tumor in which there was a rounded soft tissue thickening into the parapharyngeal space, which traveled up to foramen ovale. So this is a auriculotemporal nerve. Another case, this was post-treatment with RT given. There was a thick, if you see a structure which is traveling around the head of the mandible, you are probably dealing with a perineural along the auriculotemporal nerve. It joins this nerve. All the three nerves were thickened over here. So this was thickening along the lingual, inferior alveolar, and auriculotemporal, thickening into the foramen ovale, and there was a perineural in the Meckel's cave, as well as into the cisternal segment of the trigeminal nerve. And at the same time, there was also thickening into the foramen ovale over here. Rotundum, I'm not sure. Okay. So let's recap the normal anatomy of the mandibular nerve. So if you start tracing from the foramen ovale, the nerves comes out. It divides into three branches, that is the lingual, the inferior alveolar, and the auriculotemporal. These are the three dots which are the nerves that is seen. If you start tracing, you will start seeing in your normal patients also. One of them will go, the auriculotemporal will go posterolaterally and curve around this condyle. These two will travel like this in an anterolateral direction. One will go to the mandibular foramen and the other will go to the up to the angle of the mandible. You will be able to see them. So I have dealt with the anatomy of the mandibular nerve, that is the V3. Now we will start looking at the V1 and the V2 nerves. What happens to the V1 nerve? We have seen that the V1 and V2 had crossed the Meckel's cave and entered into the cavernous sinus. So this is their arrangement in the cavernous sinus, third, fourth, V1 and V2. This V1 will come out of these are the first year anatomy. You must be remembering these diagrams. So this V1 will come out through the superior orbital fissure, and while coming out, it divides into lacrimal, frontal, and nasociliary nerve, which supplies to the area of the lacrimal gland and some parts of the frontal part. The second nerve will divide, comes out through the foramen rotundum. It will divide into branches like zygomaticotemporal, zygomaticofacial, a big branch that we will see, that is the infraorbital nerve. It will give branches to this Vidian nerve, that is this fifth and the seventh communication over here, which supplies the palate and also the nasal cavity. So this was a case of lacrimal gland adenoid cystic carcinoma. Now we know the moment we see adenoid cystic, the antennae should be up for any perineural. There were nodules seen around the skin, which were probably connected with a linear structure. Not very sure whether it was a perineural or not, but at the same time, there was thickening of the nerve in the cavernous sinus, so probably a perineural along the V1. Another case of lacrimal gland adenoid cystic carcinomas, it was extending up to the apex. And there was some asymmetry in the cavernous sinus. There was enhancement seen on the apex. So this was a perineural along the V1 segment. So if you are looking at your lacrimal gland adenoid cystic carcinoma, do check your V1 nerve. Now what happens to the V2? V2 we have seen comes out through the cavernous sinus via the foramen rotundum. After coming out into the foramen rotundum, where will it land? It will obviously come out into the pterygopalatine fossa. From the pterygopalatine fossa, part of its branches enters the orbit. The infraorbital nerve comes out through the inferior orbital fissure, travels like this. You can see this nerve normally in all CTs and MR. You will actually be able to see the nerve. It comes out, enters into the infraorbital canal, and from the foramen, the infraorbital foramen, it comes out into the cheek area. So where do we look for? In the eggshell, you will see it comes out like this, enters into the infraorbital canal and comes out into this, through this foramen into the cheek region. Sagittal, the canal is seen like this. It's from the inferior orbital fissure. The canal is formed and comes out into the premaxillary space. So whenever you are dealing with a carcinoma that is of the upper alveolus or the hard palate, which gives a lot of soft tissue into the premaxillary region, do look at your infraorbital foramen. There may be widening of this foramen with a soft tissue present over here. Then you will look at all along the course of the foramen, which finally opens into this region and travels into the pterygomaxillary fissure and the fossa. That is how we see this. Sagittal, there was obvious thickening over here. And on the coronal also you will be able to make out. If you start seeing these nerves in all the normal patient, you will be very, very well versed with the anatomy of these nerves. So this was the case. The soft tissue was extending through this region into the pterygopalatine fossa, entering into the inferior orbital fissure, and finally into the foramen rotundum, as well as there was soft tissue into the cavernous sinus, right up to the, probably in this entire the cavernous sinus. So just a recap, any soft tissue into the premaxillary area, look at your infraorbital foramen, the infraorbital canal, pterygopalatine fossa, the infraorbital fissure, and also your foramen rotundum. So whenever you are dealing with any lesion of the orbit or the forehead, look at your V1 nerve, so look at your superiorbital fissure, the cavernous sinus, and the Meckel's cave. If you are dealing with a premaxillary thickening or a maxillary sinus lesion or the upper annulus or a hard palate lesion, look at your inferior orbital foramen, pterygopalatine fossa, foramen rotundum, cavernous, and the Meckel's cave. And if you are looking at your masticator space, buccal lesions, parotid or nasopharyngeal, look for the V3. Check in the ITF. Also, when we look at the trigeminal, we also see pterygopalatine fossa via foramen rotundum along the V2. So this is a retrograde V3 spread and an antegrade V2 spread of the perineural. This was a large mass of the orbit. It was extending through the Vidian canal, involving the foramen rotundum, that is involving the V2, extending to the cisternal segment. At the same time, there was soft tissue into the superior orbital fissure. The foramen rotundum, the Vidian was involved, as well as there was an involvement of the ovale. So there was a V1 involvement, a V2 involvement, retrograde involvement, and an antegrade involvement of V3 nerve, as well as a Vidian involvement through the interconnection. Coming up to the hard palate or the soft palate carcinoma. Whenever you feel that your hard palate or the soft palate carcinoma is encroaching upon the palatine canal, you have to check for your perineural. This perineural will spread up along the palatine canal, extends into the pterygopalatine fossa, and there was widening of the Vidian canal and foramen rotundum. So we will look at the anatomy, what happens over here. You will look at the palatine canal. There is a greater and a lesser palatine canal, which takes this nerve superiorly, and this canal itself becomes the pterygopalatine fossa. So the lower part of the pterygopalatine fossa is nothing but the palatine canal. This pterygopalatine fossa then carries the nerve. It will have a medial opening, that is the sphenopalatine, lateral opening, that is the pterygomaxillary fissure. Posteriorly, this will open into the Vidian as well as rotundum. And superiorly, this fossa will continue as the inferior orbital fissure. So this is the normal anatomy through which the nerve travels. So from the palatine canal superiorly, this is the continuation of the pterygopalatine fossa. It will continue superiorly into the inferior orbital fissure, laterally into the pterygomaxillary fissure and sphenopalatine. The posteriorly, the pterygopalatine fossa has three openings, that is the rotundum, the Vidian and the palatovaginal. How do you identify them? If you start scrolling on your coronal image till you get a nasal septum like this, I call it the McDonald's M. Then at that level, if you look at the ears of the M, you will find your Vidian. More laterally palatovaginal, let's not discuss it, it's a very thin canal. And just diagonally opposite, on the other side, you will find your foramen rotundum. So Vidian and foramen rotundum scroll from front behind on your coronal section. When you will see the nasal septum like an M, you will find your foramens. So, and the foramens, you will find your nerves. This is the how we see the foramen on a soft tissue window. Okay. Another case of a hard palate carcinoma where there was definite widening of the palatine canal and extension into the pterygopalatine fossa. So what is this Vidian nerve? How does it travel beyond the pterygopalatine fossa? This Vidian nerve then enters the Vidian canal. It is actually when you see the seventh nerve, as it enters into the IAC, at the genu, it gives a branch which is the from the first genu, you have the greater petrosal nerve. This greater petrosal nerve, it crosses the dura, it crosses the petrous bone, travels underneath the dura, parallel and anterior to the internal auditory, ICA, sorry, and then it receives branches from the sympathetic branches, fibers from the internal carotid plexus. These two unite together in the foramen lacerum to form the median nerve, and then median nerve travels into the median canal, comes out through the median canal through that median foramen, enters into the pterygopalatine fossa, travels inferiorly into the pterygopalatine fossa along the palatine canal to supply the palate. So for your palate lesions, you will check your palatine canal, you will check your pterygopalatine fossa, your median, travel along the median canal, you will look at your foramen lacerum, look at any enhancement anterior to the ICA, first genu and the facial nerve. This is the pathway that you will trace for your palate lesions. So this was a case when there was some enhancement parallel to the ICA, and at the same time there was an enhancement in the genu of the facial nerve. So next is the facial nerve. Since we have already started talking, let's look at the anatomy of the facial nerve. The facial nerve enters the internal auditory canal. It travels through this fallopian canal, divides into the first genu. Over here, it will give branch to form the median nerve. The rest of the nerve travels anteriorly. This is the labyrinthine segment in the middle ear. Then, sorry, this is the tympanic segment. It travels into the middle ear, takes the second bend when it travels in the facial recess, and then continues into the mastoid as a mastoid segment. Okay. Okay. And then it travels inferiorly till the stylomastoid foramen. So this is the normal pathway of the facial nerve. It is important to know this normal pathway to understand the perineural spread. On an MR, we see the cisternal segment on a CIS image very well. We look for the enhancement on a post-contrast sequence. We look for the nerve over here. Normally, you will see the faint shadow of the nerve on all patients. So this is the tympanic segment. One part will travel anteriorly. The tympanic segment will continue, and then you will see the mastoid segment as a dot on your post-contrast, especially if you are doing a thin post-contrast sequences. Ideally, there should be no enhancement seen in a normal facial nerve in a meatal segment as well as in beyond the stylomastoid foramen. Now let's look at this normal anatomy. Now how does it come out of the stylomastoid foramen? To trace your stylomastoid foramen, look at your mastoid tip. Anteromedial, you will find your styloid process. Between these two, you will find your stylomastoid foramen, and you will see the nerve as a black dot. This you can see on your thin T1 and thin T2 weighted images, both because we have fat around it. As the nerve will travel laterally, this nerve will travel like a dot. If your parotid is fatty, you will see the nerve on T1 as well as on T2. Otherwise, you will see it well on your T2. The nerve travels laterally like this as a dot. And then it will travel and come to the lateral to the retromandibular vein. So this is the normal anatomy through which this nerve will travel. So, a case of parotid carcinoma, which was extending beyond medial to this mastoid tip. That means it was going into the mastoid groove. As we travel, lateral, sorry. Sorry, change. So as this was traveling into medial to the mastoid tip, you see the stylomastoid foramen. So now it was entering into the mastoid groove. As you go on, this is the stylomastoid foramen. There was enhancement present over here. Further up, you see an enhancing structure over here. This is the perineural along the facial nerve. You will always have the opposite side to compare. So this was the mastoid segment of the facial nerve which was involved. Little enhancement, we are not sure. It may just be an inflammatory change, but the lower part of the mastoid segment was definitely involved. Now this is the tympanic segment which now has become normal. Did we miss something? Let's go back. Yes, there was a curved structure like this over here. So there was actually an enhancement into the foramen ovale, and there was also a perineural. So once you know you are looking at your parotid, you will not only look at your facial, you will also look at your auriculotemporal nerve. Another case of a parotid lesion extending into the mastoid groove, there was an enhancement of the mastoid segment of the facial nerve coming up and some faint enhancement of the tympanic segment. A case of buccal carcinoma over here, large lesion which was extending laterally. First, I thought it was probably extending along the duct. There was an enhancement that was coming right up to the parotid, and at the same time, there was an enhancement which was extending up to the mastoid groove into the expected location. At the same time, there was some enhancement that was extending medially, like this. So, this was a case of buccal carcinoma, which had spread along the buccal branch of the facial nerve, giving a perineural to the facial as well as the auriculotemporal nerve. So how does the facial gets involved? Facial gets involved either by the direct branch coming up to the mastoid segment. It may give a perineural into the auriculotemporal nerve. You will have to check your buccal nerve in certain cases and also via the median nerve. So these are the cases through which the facial nerve was involved. Now let's look at the perineural in cases of nasopharyngeal carcinoma. In nasopharyngeal carcinoma, there is a canal which is known as palatovaginal canal, which connects the roof of the nasopharynx with the pterygopalatine fossa. And if you look at the normal anatomy, it forms a V-shaped structure with the vidian. So vidian and this palatovaginal forms a V. So if you are looking at a very small nasopharyngeal carcinoma, but it is present into the roof of the nasopharynx, you may get a perineural via it into the pterygopalatine fossa. So whenever I'm looking at my nasopharyngeal carcinoma, I would always look at my post-contrast images or a T1 weighted image to check for a perineural in the pterygopalatine fossa. Another way of the spread is definitely the direct spread, which we all look at through the sphenopalatine into the pterygopalatine, pterygomaxillary, going posteriorly into the vidian. And this is the pathway of the vidian. So this is the second pathway of spread, that is direct through the sphenopalatine. Another pathway of spread in the nasopharynx is as it grows laterally, it may involve the mandibular nerve into the foramen ovale. That is the third pathway of spread. The fourth pathway, the nasopharyngeal carcinoma, have somehow a tendency to go into the petroclival suture. And from the petroclival suture, you will know it will enter into the foramen lacerum. Now we have seen which nerve is there in the foramen lacerum, that is the vidian nerve. So it may start spreading along the vidian nerve like this, that is the third mode of spread. So for all my nasopharyngeal carcinoma, I will check at my pterygopalatine fossa, I will look at my foramen ovale, and I will look at my vidian. All three may be involved in cases of nasopharyngeal carcinomas. So this was a case when the vidian was involved through the foramen lacerum, as well as foramen ovale was involved directly. Let's look at the case. This was a case of, I think, base tongue, which was involving the mandible like this. At the same time, if you look at the previous image, there was probably some ill-defined soft tissue was present medial to the carotid. And we see there was a palsy of the tongue. So this was probably a perineural along the hypoglossal, though the hypoglossal is normally not seen on any scan. I have tried to trace it many times, but it is not seen. This was probably a perineural along the hypoglossal. So what do you look for? Your tongue carcinomas, where do you look for? So lingual, I have told you where to look for. And how does the hypoglossal? I would like to check my perineural on the hypoglossal medial to the styloglossus muscle. So whenever I get a lot of soft tissue from my tongue carcinoma into the lower parapharyngeal space, I would like to look at my styloglossus and any enhancement medial to the styloglossus outside the tongue. Just a quick look about the anatomy. The hypoglossal nerve comes out to the hypoglossal canal. It remains into the carotid space medial to the internal carotid. After coming down, it travels deep to the digastric muscle, lateral to the stylomastoid, and comes lateral to the styloglossus, comes out in the groove between this hyoglossus and the mylohyoid and enters the tongue. So all these are my checkpoint to look for any enhancement in this region for the hypoglossal nerve. Okay. So in this case, there was some enhancement definitely present in this. And if this perineural spreads up to the external ECA, then the patient is difficult to operate. Some another case, this was a case of lymphoma with a perineural spread along the third nerve as well as the fifth nerve. And the nerve thickening was seen in the cavernous sinus. And finally, this was a very interesting case of a fungal infection involving both the maxillary sinuses with enhancement extending along the buccal branch, along the auriculotemporal, along V3, and in fact, all the branches of the facial nerve was involved and it was extending along the facial also. So, while concluding, it is very important to know the normal anatomy of the cranial nerves. Somehow, it's a very good habit to look for these cranial nerves on your normal scans also. To localize the lesion, once you are dealing with a lesion, to look for all the nerves in its vicinity to not to miss this perineural spread. Some mimickers of perineural spread, we do get plexus enhancement at times. Post-RT nerve starts enhancing. Sometimes due to the presence of tumor, the nerve enhances because of the inflammatory thing. So subtle nerve enhancement, you should tell your clinician you are not very sure, but there is enhancement of these nerves. So with this, I would like to thank you for this patience listening. And I'm sorry there was a lot of interruptions. You can put some questions if you want.
So that was an excellent talk, really amazing, and beautiful images. I think this phenomenal images, and the way you traced the anatomy was great. If anyone has any questions, please put them on the Q&A. Okay, so Hina is asking you to suggest any article for normal anatomy of foramens and nerves. Vasu, sure if you can hear me. Can you hear me, Vasu?
Sorry. Regarding the references, there are some articles on the on these perineural spread, but it is a very good exercise to know the normal anatomy and the course of the nerve as well as the foramen. Then you will start picking up the perineural spread.
If there's any article which gives this nicely, then we can share it on the groups, or if there's any.
Okay. Now the lingual nerve travels through the lingual canal along the medial surface of the mandible, and then it comes out into the parapharyngeal space. It travels just along with the inferior alveolar nerve, a little anterior to it. Whereas this hypoglossal nerve, it enters the tongue between the styloglossus and the mylohyoid muscle. So through where the submandibular duct enters into the tongue, this hypoglossal also enters at that.
There are also some questions in the Q&A.
I'm sorry, my net is not, I think, stable
Okay.
today.
So this is an anonymous attendee asking how to differentiate post-radiation changes from perineural spread.
I can't hear. I'm only able to see the chats.
Okay. Try the Q&A. Let me put it on the chat box itself.
Okay, I'll check the Q&A. Okay. CT and MR protocol of the perineural. See, one thing you have to keep in mind that you have to take thin images for MR. CT, there is no specific protocol. We make use of the CT as a secondary sign to look for any nerve thickening or enhancement, but we do a routine multiplanar CT. As far as the MR is concerned, keep in mind we need thin images. We need a contrast with the nerve, and the fat gives this contrast. So don't use a fat set. Use very thin images, 3 mm, contiguous slice if possible, and take a 3D post-contrast sequence. Whenever you are looking at the nerves outside the cranium, inside the cranium, your cis will help, and a post-contrast fat set sequence. Slice thickness, you can go up to 3 mm without gap. No, facial nerve I can identify up to the main facial nerve, and if one of the particular branches are thickened, but not the remaining, not the branches. It is very, I'm not able to identify the further branches of the facial nerve. V1 division. Okay. Now this V1, in the Meckel's cave, the nerve divides into three. The V1 is the first division. It immediately enters, pierces the dura and enters into the cavernous sinus. In the cavernous sinus, it travels anteriorly, comes out of the cavernous sinus through the superior orbital fissure. By that time, it divides into frontal, lacrimal, and nasociliary, and then supplies the orbit and part of the skin adjacent to the orbit. Auriculotemporal nerve. Okay, let's trace the auriculotemporal nerve. So this mandibular nerve divides into three over here, the lingual, the inferior alveolar, and the auriculotemporal. This auriculotemporal will travel posterolaterally and will encase this condyle like this. So look for any abnormal enhancement in this direction and you will get your auriculotemporal nerve. This is a thickened auriculotemporal nerve on the right hand side. Okay. RT changes versus perineural, how to differentiate it. It is really difficult to differentiate initially because the RT causes thickening of the nerve and enhancement along this nerve. So you are not very sure, are we really dealing with perineural? But if it was not present in your previous scan, or if there is not significant associated soft tissue with it, it may be just post-RT thickening. It is a normal phenomena to get an enhancement into the pterygopalatine fossa and along the nerves. In this, initially you will not be able to differentiate it. That was a lymphoma also near the fourth ventricle. We do see nerve thickening in many other conditions. IgG, we deal in an onco institute, so we mostly see the malignant cases. Benign cases, I have no idea for the perineural, though it is perineural by definition happens in both benign and malignant condition. And that fungal was one of the thing we saw perineural in that. I really don't remember from where I have read, but you will have to read the anatomy of the skull base and the individual nerves also for this. There are many articles on perineural spread. Greater petrosal nerve. Okay. So the facial nerve, which is marked by this one, enters into the internal auditory canal till it reaches the first genu. At the first genu, it then gives a branch, which is the Number second, then that is the greater petrosal nerve. This greater petrosal nerve travels under the dura. It crosses the petrous bone and enters into the middle uh, middle fossa. It travels anteriorly under the dura, anterior to the carotid canal, and comes to foramen lacerum. In the foramen lacerum, it receives the sympathetic branch from this carotid, that is known as the number four, that is the deep petrosal nerve. They together combine and form the Vidian nerve, which then travels into this Vidian canal and comes out through the Vidian foramen into the pterygopalatine fossa. In the pterygopalatine fossa, it does receive branches from the maxillary nerve. That is how the fifth and the seventh nerve communicates over here. Travels inferiorly as the palatine nerve, also gives branches to the nasal cavity and the sinuses. Okay. RT versus perineal spread. Difficult to see, but once like if we start getting a soft tissue, we know that there is a relapse. In CECT, we report a lot of buccal mucosa on CECT. Most of the time, if we are sure, we don't ask for an MRI, but the eyes are trained for it. Especially, but like if you are not sure, ask for an MR. Ideally, MR should be the modality of choice. The communication between fifth and seventh happens in the parotid itself through this, and then that is how the auriculotemporal nerve gets involved. More cases, maybe next time. Facial once more. Okay. Yeah, this presentation was part of it. Presentation was sent to RSNA, so it is there on the site. Now facial. I'll tell you the facial ones. Okay. So facial, we should know on the bony part, bony as well as on the MR. We know that the cisternal segment comes into the internal auditory canal. We have a canal over here through which the facial travels, and then it divides into the first genu and gives the petrosal. The second part, the rest of continues as the tympanic segment. Just underneath the lateral semicircular canal, you see this dot, that is the tympanic segment of the facial nerve. It continues behind till it again takes a 90-degree turn, that is the second genu. Second genu then continues behind like a soft tissue in the mastoid space, which we call as a facial recess. You can see the mastoid segment as a soft tissue of pacification in the mastoid hair cells, comes out through the stylomastoid foramen. So this is how we can reconstruct it. It is very interesting to see this facial nerve on an MR. If you do your MR and take a post-contrast thin images, you can see this nerve in all patients. They are not non-enhancing, but you can see the nerve like this traveling behind and then the mastoid segment. So for a thin T2, for the brain, for a thin post-contrast images for the brain, start looking at your facial nerve. You will see the entire facial nerve till it comes out with the through the stylomastoid foramen. Okay. Palatine canal and its boundaries. Okay, I'll show this. First, I'll take this analysis of fat set, non-fat set, with or without contrast. Once you make a fat set, now you won't be able to see thin nerves. We do take one stir to look for any obvious appearing thickened nerve. But for little thickening of the nerve, you will not be able to see if you don't do a fat set. Somehow we have the habit of doing a non-fat set, thin T1 and T2, and a stir coronal image plus a post-contrast image. With all the three, we are able to tell whether it is perineural or not. If we have doubt about the perineural, we tell our surgeon probably we are thinking there is perineural. They ideally then they do either a sampling or look for that, do a frozen and accordingly decide. Now palatine canal. So we have seen that the palatine nerve travels like this in the palate and enters into this canal. There is a greater and the lesser palatine canal over here. This palatine canal then travels superiorly, and the palatine canal itself becomes the pterygopalatine fossa. So if you look on your coronal, this is how the palatine canal will look like. Yeah. So this is the palate. From there you get the palatine canal. This you will be able to see on your CT very well. The canal travels superiorly, and this canal itself becomes the lower part of the pterygopalatine fossa. I think I have taken most of them. Let's see if there's any. We deal with mostly malignancies. For all malignant lesions, if it is in the vicinity of the perineural, we look at the nerve perineural for that area. Like whenever we are looking at facial, I would like to look at my stylomastoid foramen, whether there is a direct extension of perineural. If I'm looking at my buccal and I know my buccal is sitting on my mental foramen, I will trace my inferior areola. If I'm looking for a lacrimal gland, I will look at my superior orbital fissure. If I'm looking at my maxillary sinus lesion, I will look at my foramen rotundum. That is a habit which has formed after reporting the head and neck malignancies. Okay. One more question. Pterygopalatine fossa and canals. Okay. So we have seen, I stopped at the palatine. So when the palatine continues superiorly, it forms the pterygopalatine fossa. This pterygopalatine fossa has certain openings. Medially, it will open via the sphenopalatine foramen. Medially, it will open via the sphenopalatine foramen into the nasal cavity, and laterally, this opening is the pterygomaxillary fissure through which it opens into the ITF. That is the medial and the lateral opening. Superiorly, the fossa itself will continue into the inferior orbital fissure. There are three openings in the posterior wall. The first opening, which is straight like this, is the Vidian canal, which will go up to the foramen lacerum. There is another opening over here, that is the palatovaginal canal, which will form a V shape with the Vidian, and more superiorly, we will find a foramen rotundum. Okay. These are the openings of the pterygopalatine fossa and its boundaries. If we look at the coronal image, the pterygopalatine fossa will open medially through this opening into the nasal cavity, that is the sphenopalatine. Laterally, it will open into the infraorbital fissure, into the ITF, that is infraorbital fossa, through the pterygomaxillary fissure. Superiorly, just like the palatine canal has continued into the pterygopalatine fossa, the pterygopalatine fossa continues into the orbit through this is the inferior orbital fissure. And then in the posterior wall, you have the three openings, the Vidian canal, the palatovaginal canal, and the foramen rotundum. So,
Vasu, can you hear me?
yeah, I can hear you now. Sorry.
Great. Well, thank you so much. This was phenomenal. And thank you for patiently answering all the questions. I think all of them have been answered. And just the number of questions tells you how interested the people are, right? And especially this last bit of information that you gave, which nerve to look when depending on the tumor site. That was, I think, phenomenal. I hope that's a table on your RSN and PPT, or it comes out as an article soon. I think that will be very useful. But thank you so much for this. And I should actually read the comments on the chat box.